Hi, and welcome to Conversations in Interventional Cardiology. My name is Andy Goldsweig. I'm an interventional cardiologist at the University of Nebraska Medical Center in Omaha and associate editor of JSCAI, the Journal of the Society for Cardiovascular Angiography and Interventions. I'm honored to represent JSCAI and our editor-in-chief, Dr. Alexandra Lansky. You can find us online at JSCAI.org and follow us on Twitter at myjscai, at myjscai. JSCAI is home to all official SCAI documents. We're here today to discuss an important recent publication in JSCAI on acute kidney injury in transcatheter aortic valve replacement. We have an esteemed panel of internationally renowned experts. First, we have Dr. Sarah Gualano, the first author of the paper, and an associate professor at the University of Michigan Health Systems. And then we have Dr. Charles Davidson, vice chairman of the Department of Medicine and chief of cardiology at Northwestern University. So first, Dr. Gualano, thank you so much for joining us. In this paper, your work on acute kidney injury associated with transcatheter aortic valve replacement, really, you shed new light on preventing this common and serious complication. Can you describe your group's findings for our listeners?
Yeah, I'd be happy to. I'd like to share some slides with the group. Excellent. So on behalf of my co-authors, I'm really thrilled to have this opportunity. Here are our authors' disclosures. I'll just leave this on the screen for a second. So we all know that acute kidney injury can be an occurrence after contrast-guided procedures such as coronary intervention or peripheral vascular intervention. And it's long been established that this is associated with adverse outcomes, including mortality. We even see AKI after cardiac surgery, such as CABG and valve replacement, also leading to mortality. Reports of AKI in patients undergoing TAVR have also demonstrated increased risk of mortality, though the role of contrast volume in this development of AKI is a little bit unclear. For example, in a recent publication from the TVT registry, 10% of patients had developed AKI greater than stage 3. And those patients had a 7 times increased risk of mortality in that publication. The authors of that study used contrast volume, just kind of 2 big buckets, greater than 100 cc's or less than 100 cc's. And it was kind of weakly predictive of AKI. But otherwise, there's not been a more nuanced kind of description of the role of contrast volume in TAVR that's shown any kind of predictive value. So previous studies, including PCI and peripheral vascular interventions, have demonstrated that a contrast volume greater than 3 times contrast clearance was associated with increased risk of contrast nephropathy. And a similar threshold for our patients undergoing TAVR has yet to be established. And so that was really the purpose of our study, is to look at the incidence, risk factors, survival implications, and role of contrast in the development of AKI after TAVR in a contemporary practice throughout the state of Michigan. So for this study, we used data from the Michigan Transcatheter Aortic Valve Replacement, or MyTAVR registry. Since actually the paper was submitted and published, the name is actually changed to the Michigan Structural Heart Consortium, so not to cause some confusion for some of our readers. But Michigan TAVR is a regional collaboration between the Michigan Society of Thoracic and Cardiovascular Surgeons and the Blue Cross Blue Shield of Michigan Cardiovascular Consortium, or BMC2. And the registry is really designed to improve the quality of care and outcomes among patients undergoing TAVR within the state of Michigan. And all Michigan TAVR programs currently participate, with the exception of the VA hospital, just because of federal constraints. So data is collected on consecutive patients that undergo TAVR at all of our participating programs. And we use the TVT registry and standardized data forms to acquire the data. And so the endpoints are all as defined within the TVT database. Unique to Michigan TAVR is that data quality and completeness are confirmed by TVT, but enhanced by on-site audits by BMC squared trained representatives at all Michigan TAVR hospitals. And so we feel it provides a higher level of accuracy potentially. For this study, our study endpoints, again, those kind of in accordance with TVT definitions, looking at pre-procedure creatinine, peak creatinine, discharge creatinine. AKI was defined as a creatinine increase to at least stage 1 of the AKIN classification system, according to the VARC-2 criteria. Again, published, this was performed prior to the VARC-3 endpoint release. So our study population, we included patients between January 2016 and December 2019. We really wanted to focus on a contemporary population within the state, looking at current generation or nearly current generation TAVR valves. There were 7,432 consecutive cases, and the 3.6% of patients who were on dialysis were excluded, and as well as patients with missing creatinine values, which luckily only represented about 1% of that population. Our mean age was just under 80 years old. 53% of the population was male. Our STS predicted risk of mortality mean score was 5.8, and we had pretty good follow-up of a median follow-up of 345 days. So similar to a lot of other TAVR populations with it, which have been described. AKI occurred in 8.8% of our patients, and 8% of patients were dead within 1 year. And this was including the 1.2% of in-hospital deaths of patients. So after, excuse me, after multivariable analysis, these are some of the adjusted patient and procedural factors which were significantly associated with AKI. And you'll see kind of our contrast thresholds at the top, which I'll kind of go into more detail a little bit later. But also other factors which have been previously described, such as like general anesthesia use, baseline creatinine, and you can I'd refer you to our paper for more detail on some of the patient demographics and these procedural factors. We also then wanted to look at AKI by contrast volume indexed to eGFR. And so we looked at sort of integer buckets of that ratio, less than 1, 1 to 2, 2 to 3, 3 to 4, and then greater than 4. And one can see as you look at the plot along the x-axis that kind of the ratio of less than 1 and 1 to 2 are roughly about the same, but at that kind of 2 to 3 integer bucket, you start to see an increase in the rate of AKI with a dramatic, obviously, risk at the ratio of greater than 4. And so we thought that this was notable and wanted to explore this a little bit further, looking for a specific threshold or cut point that one could use to really predict the risk of AKI. And so we performed 2 different ROC analyses using the Uden ROC1 index methods, and found a cut point with the Uden method of about 2.25 and with ROC 2.0. So somewhat similar to the PCI and PVI studies that had been performed previously. So looking at procedural characteristics that predict AKI, again, after a multivariable adjustment, we found that contrast volume of both greater than, contrast volume by eGFR ratio of greater than 2 and greater than 3 were both predictive of AKI. We chose to look at both greater than 2 and greater than 3, obviously the greater than 2 threshold, because that was what was predicted by the ROC analysis. But since the greater than 3 threshold was used in prior PCI and PVI studies, and it was a little bit more discriminatory in terms of the number of patients that fell into that bucket, we wanted to see if both of those cut points were relevant. And then again, similar to other studies, we found that the use of general anesthesia was also predictive of AKI. And so looking at the mortality analysis, again, we demonstrated that patients who had suffered AKI had an increased risk of mortality even after multivariable adjustment with a hazard ratio of 4.5. This was true both within the first 90 days as well as up to the year follow-up for patients. So the conclusions of our study was that contrast volume in the context of renal function is a robust tool to predict AKI during TAVR. And we believe this is the first to really kind of look at a practical threshold, which may be used during TAVR procedures to try to avoid AKI. And that instead of looking at the contrast volume as a continuous variable or in just a very large bucket of less than or greater than 100 cc's, that this might be a specifically patient-tailored tool to try to avoid AKI. Again, after adjusting for patient characteristics, procedural factors such as that ratio greater than 3, greater than 2, and use of general anesthesia were significantly associated with that risk of AKI. We also found, again, kind of parallel to other publications, that AKI unfortunately remains common after TAVR in a real-world registry, and it remains independently associated with 1-year mortality. And we would suggest that procedural factors such as contrast volume by indexed by renal function really provides a potential target for quality improvement initiatives at TAVR sites. Personally at our 2 TAVR sites here in Ann Arbor, we include that ratio of greater than 2 and greater than 3, like the volume cutoff per patient, and as part of the timeout prior to our TAVR procedures now. So I appreciate the opportunity to share a little bit of the work that we did on our study, and I'll stop sharing my screen now.
Wonderful. Dr. Gualano, thank you so very much. That's really fantastic information and a fantastic presentation as well. Turning to you, Dr. Davidson, question to kind of launch the discussion is, how will this new and important knowledge fit into the interventional cardiologist's workflow and toolkit? How will this change practice in terms of patient selection, in terms of procedural planning, in terms of patient monitoring?
Well, I think this was an excellent study by Dr. Gualano and her colleagues on the topic of contrast-associated acute kidney injury, which has been a topic that's been around for years with PCI and now into the TAVR world. And I think there were things that we learned early on, and that was contrast dose, prehydration, baseline GFR, and diabetes were highly predictive of adverse events and AKI and even late events, as she pointed out in this study. I find it very interesting, though, that now we can hone in on a topic that really should be near and dear to cardiologists already, which is limiting contrast dose. I was struck in this study that the average dose of contrast was about 106 cc's, 113 cc's. It was pretty darn high for an average TAVR, but it just goes to show you that people are not aware. So I think what this study does is raise awareness. We need a body of literature so people walk in there and do a procedure, and whether they have baseline kidney disease or not, that should be part of your algorithm. And I guess the other piece I really learned from this was that general anesthesia is not your best friend. And then that was being utilized in 1/3 of patients. And I know this was done in a little bit earlier time when it was mostly intermediate and high-risk patients. And so the practice may have evolved in the last few years, and hopefully it has, but it's really not a reason to be using GA in patients. And we know it predicts, again, AKI in an average patient that's getting a transfemoral access. And so I think the take-home messages for me is keep your contrast dose as low as possible. And I like having a nice simple measure like this that you can use. And also let's try to avoid using GA unless it's absolutely indicated.
Great points. Question for both of you. Dr. Gualano, you had commented about PCI and peripheral vascular intervention. Is contrast dose in TAVR potentially different than those, I wonder? The physiology of the patients, particularly pre-procedure when they have constraints on their cardiac output, is the contrast limitation of 3 that we often talk about in coronary intervention potentially inappropriate in TAVR, in light of your findings?
Yeah, I mean, when you look at the odds ratios, the numbers, the point estimates are not too different. So even though there's probably a little bit, according to the ROC analysis, the 2 might be a little bit more discriminatory. I don't think the magnitude of that difference is super large. So, I think that the incorporating both of those numbers as part of the timeout or kind of awareness of the procedure is reasonable. Ideally, the goal would be less than 2 times, the GFR. But sometimes, we've kind of empowered some of our staff in TAVRs to kind of give us warnings, like getting close to the threshold, et cetera. And, if one exceeded that 2 times threshold, but was trying to really stay under the 3 times threshold, is that something that would be meaningful? But I think we all have seen in prior studies that that renal function in these patients really is harmed by aortic stenosis. With a large number of patients with renal function abnormalities at baseline can actually improve post TAVR with the kind of cardiorenal syndrome, et cetera. And so I'm sure that they're different, compared to the PCI versus PVI patients, as you described. I think most of the time, technically, we can get under that 2 times threshold, but really kind of doing everything in your power to avoid, going over that 3 times threshold is important.
If I could pick up on a couple of things, because I think you made some great points there. One of the things that is different is we're inducing hypotension during these procedures, right? And we know that's also a risk factor for acute kidney injury. Now, usually it's fairly transient, but I could see someone doing multiple runs or longer runs. That's something. Another area which we are a little limited on is prehydration, which we generally do with our coronary patients, particularly preserve function. But even these patients with preserved function, you're going to be limited on the amount of prehydration that you can utilize in the population. And I think to Sarah's point as well, that really, if you have a patient with CKD, there's no reason to really need more than about 20 to 30 cc's of contrast to do a procedure. Really, you can do a baseline aortogram. You need to do a femoral shot maybe on the way in, and really on the way out, maybe a femoral shot or just check pulses. But really, that should be about all you need is your baseline aortogram, deployment aortogram, and a couple peripheral shots that should be no more than 5 cc's each. And I think that's where this teaching needs to get across. So we don't have to do multiple aortograms. Right? We don't have to really use a lot of contrast in an average case where there's no other complications going on.
Those are some great points, Dr. Davidson. I wondered if I could ask you to expand a little bit on what you said about reducing contrast dose. So certainly, baseline aortogram and a deployment aortogram and potentially a femoral angiogram somewhere in the way. But are there techniques, are there imaging technologies that can help people to avoid contrast use even further?
Yeah, I mean, I know my average one is a 20 cc 50-50 mix of contrast and saline. What I'll do sometimes is I'll drop that down to 15 cc's and just increase the rate to 30 or so. So a little higher rate, but a little less contrast. And so 2 shots there, you're really 15 times 15, 15, 30, and they're half dosed. So it's 15 cc's, and then same thing for the peripheral arteriogram. So I think those are simple techniques. I don't know, what the 2 of you are thinking, but those are things that I generally use.
Yeah, agreed. I think at our center, we frequently use the 3 foreign bodies in the 3 aortic cusps technique. So, whether it's 2 pigtails in a wire, 2 wires in a pigtail, 1 foreign body in each aortic cusp, and just use fluoroscopy to confirm the coplanar angle, trying to avoid the use of contrast.
Yeah, we've done that. We've also kind of decreased our aortogram contrast totals to like 10 cc injections, during deployment. And even unless the root is just massive, you can see adequately to get perfect deployment. And then also for us, we for kind of analysis of the femoral access after sheath kind of withdrawal, we've gone from the contralateral side and taken very subselective angiograms of the external iliac, really avoiding contrast going anywhere else in the body except the targeted vessel that you're trying to see for your common femoral access. So I totally agree. I think once you become intentional and really mindful of what you're doing, you can really get a very low dose.
Excellent. Well, this is really an important paper, and I think this is something that's going to be very important moving forward as TAVR continues to expand. Any final points either of you would like to add for our listeners who are eager to reduce their contrast dose and protect their patients' kidneys?
So I'll give you the final word here.
I think I would just kind of restate what I just said, that looking at each step of the procedure and thinking about how one might be able to do it differently, ultrasound access at the beginning of procedures, and, only really putting contrast where you absolutely need it. I totally agree. I love the double pigtail technique in the sinuses. I think that's really, really great. And, limiting the aortogram to like the single deployment in aortogram, if you're using like balloon expandable technology, for example. So yeah, I think, just being very intentional about every step of the procedure, you can really get that number down.
Excellent. Well, thank you very much, Dr. Gualano, Dr. Davidson. We're thrilled to include this important paper in the third issue of JSCAI, and also to share this discussion with you, our incredible panel, with all of our listeners and readers. To everyone, please follow JSCAI online, jscai.org, on Twitter, @myjsci, and submit your own work to JSCAI, the official journal of SCAI. Thank you very much.
Thank you.